Hello and welcome to Basic Airway Management. This is Module 1 of the Anaesthetic Assistance Airway Training course. Today we'll chat about goals of this course, some knowledge that we'll need to have to proceed with airway skills, focusing a lot on the team skills, and then at the end, in practical groups, we hope to go through some airway skills. So today our goals are to obtain an appreciation of the equipment and staff requirements of basic airway management. And the real goal is to be able to open, maintain and provide mask ventilation to a patient. And these are the most basic yet the most essential skills in airway management, and upon all the advanced airway management treatments are based on. So what do we really need to know? So what is the upper airway and how does it become obstructed? What's the difference between oxygenation and ventilation and what are they? What can we do to help reduce the likelihood of airway obstruction? And who will be difficult to oxygenate and ventilate? What is the upper airway and how does it become obstructed? As you can see from the image on the left side of the screen, everything above the vocal cords, the hypopharynx, oropharynx, nasopharynx, the oral cavity itself, and the nasal cavity, anterior nasal cavity, are all form part of the upper airway. When we talk about the airway becoming obstructed, we are talking about the tongue and the epiglottis and the oro, especially oro and hypopharynx, becoming in a more relaxed state, and the tongue falling back and causing that patent tube, as you can see there, or open tube, from the nose, from the mouth, down to the trachea being all nice and open, to that being collapsed and shut. And the two most common ways for that to occur in the hospital are for us giving our anaesthetic drugs, so the drugs that drift us off to sleep, the drugs that are to reduce anxiety, the painkillers, and also the muscle relaxant drugs, all will cause relaxation of the tissues in the upper airway to cause obstruction. The other common group that we'll see are those patients that are terribly unwell, that maybe have suffered cardiac arrest or have become so tired due to increased work of breathing efforts that they are now falling asleep and are unable to be awake enough to keep their airway open. What is oxygenation and ventilation? A key concept to understand, first of all, is respiration, a key chemical process in all the cells of our body that keeps us and our cells alive. For this to happen, oxygen and a fuel source such as carbohydrate or sugar is then transformed into energy, other chemical processes, and carbon dioxide as a byproduct. So our bodies consume oxygen and produce CO2. So in thinking about oxygenation, we need a patent or open upper airway to give oxygen into the nose or mouth, into the pharynx, and then into the trachea, and then into the lungs, where they can then get into the red blood cells. And then ventilation is whenever those red blood cells have visited a cell or a tissue that needs oxygen, gives them that oxygen, and then picks up the byproduct of respiration as CO2, and then that red blood cell goes round your circulation to return to the lungs, and then dissolves out the CO2 into your lungs, and you breathing in and out breathes in more oxygen, and then breathing out allows you to get rid of the CO2 that your body has made. And this is the difference between oxygenation and ventilation, but they both work hand in hand. So we need to take more oxygen in all the time, and we also need to get rid of the CO2 produced by respiration all the time. But these are essential functions that go hand in hand to maintain life. What can we do to help airway obstruction? So first of all, if a patient's coming into theatre, make sure they're correctly positioned on the theatre bed. Apply all the monitors to make sure that they're all working and they're getting good signals, good clear pictures, and your alarms are all set correctly. And you want to ask the patient to be in that sniffing the morning hour position, and we'll go through that in the practical elements of the course later. We want to make sure that we have the right size of anaesthetic face mask and that the placement is correct. It's covering the nose, covering the mouth, and that we're getting a good seal on the mask if the patient is spontaneously breathing. And we want to make sure our hands positions are good in that it gives a good tight seal around the face without causing patient discomfort if the patient's awake. We'll talk in more detail about chin lift and jaw thrust in the practical sessions, but these are essential in basic airway management to open the upper airway. Also then, if chin lift and jaw thrust are not good enough to maintain the airway, the use of Guedel or oropharyngeal airways or nasopharyngeal airways will be discussed. So who is difficult to oxygenate and ventilate? So this poor chap here, Boots, is a good acronym to remember. So if somebody's got a big bushy beard, the mask is very difficult to sit on. The high BMI patient, the obese patient, sometimes there's a lot of neck and a lot of tissue around the face, and the mask may be difficult to seat. They also may have just more tissue to oxygenate, and they are more difficult to ventilate because of the tissues around their chest wall or their tummy whenever they're lying flat, and they're more difficult to properly position. And I would just be extra careful in positioning of the high BMI patient, as it's also a risk for moving and handling, and they will desaturate quicker. Those who are older, because they've got less physiological reserve, they will get sicker quicker. Those who have less teeth are more difficult to mask ventilate, as you can't get a very good seal on the mouth if there's no teeth in there. The mouth loses a lot of its structure and it's hard to hold the mask around it. And those who snore already, a bit like myself, obstruct their airways whenever they're asleep. So even if they're a little bit unwell or having a little bit of anaesthetic medication, their airways will obstruct sooner than that person who doesn't normally snore whenever they're asleep. And the other group of patients that we have to be wary of and who's difficult to oxygenate and ventilate are those who are already on our medical wards, who are in A&E, that are receiving quite a high amount of oxygen on the ward already and maybe don't have normal saturations. These patients need extra care and attention prior to inducing anesthesia or manipulating airway, or to then put on mechanical ventilation. They will desaturate a lot quicker, and basic airway management is so much more essential in this group of patients. Team skills are a huge thing that we never really talk about. We talk a lot about our practical skills and our anatomy and things, but I think all of us as a team should be aware of these factors. We need to be in the right mind, we need to be in the right place, we need to have the right people around us, and we need the right stuff to do the job. The right mind is being patient with our colleagues, try to know each other's names. We're very lucky in Craigavon to have excellent nursing team and medical team, and I think we have a great working relationship most of the time, but it's essential that we know each other and know what each other can and can't do, and know where the people who can do something or know where the equipment is kept, know where those people are. We need to be in the right place. If we're on the ward, we want to go back to theatre or go back to intensive care, those are the safest places to do advanced airway manoeuvres, but the basic airway management will occur wherever that patient has become unwell. But we need to then weigh up, is it safer to move or safer to stay? And the right people. Do we have the right people around us? Do we need a more skilled anaesthetic nurse? Do we need a more senior anaesthetist? Do we need an anaesthetic doctor? Because sometimes there may not be an anaesthetic doctor if we're in the intensive care. There may be a more junior member of medical staff who may not be as confident in airway management. So always try to know, oh, this is the doctor, but what is their grade or qualification? And the right equipment. Do you know where the next piece of equipment that the doctor or nurse may need? And we'll go through those things later on in the course, and where the trolleys are and what the urgent things are. Teamwork does make the dream work, and we're very lucky in Craigavon to have great medical and nursing teams. Your tutor will now go through basic airway skills. Thanks very much, and I hope you enjoy the clinical stations. Thank you.